start the session. Thank you everybody for coming to this honorary symposium in honor of Professor Ajit Yoganathan, his retirement after 40 plus years of scholarship, service, as well as mentorship for all of us. So we are here today to just celebrate and reminisce into the past in honor. So we have several speakers. So our first speaker is going to be our keynote speaker, Professor Mark Fogel. And I'm going to go ahead and ask Dr. Fogel to come forward, give his talk. Please welcome Mark.
Thank you very much. And I want to thank Prasad and Keith and everybody, all the organizing committee, giving me the opportunity today to pay tribute to Ajit and his contributions to Fontan Research and my partner in crime in Fontan Research. So I first wanted to talk about the man himself. Currently, he's the Emeritus Regents Professor and Wallace A. Coulter Distinguished Faculty Chair in the Department of Biomedical Engineering at Georgia Tech. His education, he graduated from UCL with a BS in London in 1973, and 1978 he graduated with his PhD from that little school out west, the MIT of the West, as we call them. I graduated from MIT in 1978 from Caltech. And he's held multiple positions over his illustrious career. So, and I can't go through all of them, but clearly his last position, the director of the Center for Innovative Cardiovascular Technologies at Georgia Tech. But if I did all his positions, I would waste all my 15 minutes up here that I can talk. So just to say, these are some of the more recent ones and some of the highlights. In terms of the honors, same thing. I could talk for 15 minutes about the whole list of honors. The ones I wanted to highlight is in 2015, he was inducted into the National Academy of Engineering, and here he is getting his diploma. He got the Lifetime Achievement Award, the inaugural one, from the Heart Valve Society, and here's a picture from the poster of that. He's won a number of other awards, the Listener Award, the Theo Pilkin Award, the Pritzker Award, and here he is at the Pritzker Award accepting the award from Bench to Bedside, a journey through translational research. And a number of many other awards over the course of many years. Again, if I said them all, I would use my full 15 minutes, so I have to put it into the etc. But I do want to point out he was the annual lecturer at Children's Hospital of Philadelphia, where I worked in 2016. So, since I'm talking to a whole bunch of bioengineers, we have to do Ajit Yoganathan by the numbers. So here we go. The sum of all his preceding presentations, both with and without papers, the total is 899. And the only thing I could ask is, you couldn't stay for one more? You couldn't make it a cool 900? Come on, can somebody in the audience please put him on one abstract so he can make it a cool 900? And same thing, you're going to notice a pattern here. The same thing with his peer-reviewed papers. The integral of all his papers from 1975 to the present is 489. You mean to say you couldn't hang on for 11 more? So I'm going to put him on a paper. If I get 10 volunteers, we can make him hit the 500 mark during his retirement. 315 lectures, 129 mentorships or training of PhD students, master's degree, postdocs, visiting staff. 99 bottles of bourbon somewhere, holder of 20 patents, and one founding editorship of cardiovascular engineering and technology. Here is a picture of him, one of the more recent pictures from the staff in his lab. And speaking of cardiovascular engineering and technology, there was a special issue that was devoted just to him for his 40th anniversary that was published in 2021. 10 articles on the shaping of the field of cardiovascular fluid mechanics. A good read. I hope if you've get the opportunity to pick it up, 10 articles. I just want to talk a little bit about how I got to know Ajit. When I was a fellow and I was trying to understand cardiovascular fluid mechanics and blood flow and Doppler imaging, I read this book, Doppler Echocardiography, and chapters 4 and 5, Ajit was the senior author, and I remember that was the first time I actually understood it. And so I thought, that's pretty cool, I got to meet this guy. And so I got up the gumption as a junior attending to call them. I cold called them in 1999 and had drinks with him at the American College of Cardiology, the first meeting with him. And then in the early 2000s, we partnered up to get a bioengineering research partnership from NIH, creating a Fontan registry with cardiac MRIs, and we'll talk about what a Fontan is in a second. And in the mid-2000s, we began our surgical planning effort with Ajit leading the charge again with Fontans, which I'll talk about in a second. And then in the later 2000s, we submitted and got an NIH R01, looking at exercise performance and quality of life measures with cardiac MRI bicycles. And then in the mid-2010s, we had various other Fontan projects. So I promised you that I would tell you a little bit about what a Fontan is and Ajit's contributions to our research and our field. But to get everybody on the same page, I just wanted to take a minute to talk a little bit about what a Fontan is so we all know what we're talking about. It has to do with single ventricles, and as you can see here, this is what a normal heart is with 4 chambers. Here's an MRI of the heart beating. In a single ventricle, there's just one pumping chamber, and it's generally small, if not absent, and the whole left side is small, and the only way blood gets out, for example, in this particular instance, in hypoplastic left heart syndrome, hypoplastic meaning small left heart syndrome, is going through this little blood vessel called the patent ductus arteriosus, and here you can see an MRI of that tiny little heart. It's repaired in stages, and then ultimately it winds up in a thing called the Fontan operation, where superior vena cava blood and inferior vena cava blood are baffled so that blood flows passively into the lungs. And it's this region here, the Fontan pathway, that you can see here, passively letting blood flow into the lungs, is the cause of all sorts of clinical problems that we see clinically with these patients. All these complications: poor heart function, heart failure, thromboembolism, meaning developing blood clots, abnormal heart beating, poor exercise performance, and the list goes on and on and on. So Ajit decided that he was going to put his mind towards studying this using biomechanics and computational modeling and obtaining metrics such as power loss and resistance and Reynolds number. You guys know the drill with that. And when I looked at Ajit's CV that he recently sent me, I wanted to get the most up to date. I noticed a pattern, that there was a pattern to his research in computational modeling and with cardiac MRI. And the first bucket really in the early stages was understanding flows in the Fontan pathway. And then that kind of moved to the next stage, which is surgical planning, which we'll talk about in a second. And then finally, the last stage was taking this all together, and how is that going to affect patients? How does this relate to patients? So I'm going to go through these one by one, just a little bit about each. So in Understanding Fluid Mechanics, this was one of the first papers published in 1996, where Ajit used these simplified glass models and a high-speed camera to look at the blood flow. And you can see it wasn't just pretty pictures, he was able to actually quantify power loss depending upon the anatomic arrangements. As the years went on, the analysis got more and more sophisticated, which you can see here on the left. And here's one example of one paper that we published together in 2014, looking at geometry and its effects on hemodynamics. We looked at things such as vessel dimensions, vessel offset, and correction and connection angle. And as you can see, for example, in this graph, where we use power loss on the y-axis and the diameter of the left pulmonary artery on the x-axis, you can see that as the diameter goes down, there's an exponential increase in power loss. And then I don't know what went through Ajit's head, but maybe one day he said, hey, wait a minute, we're doing this on a computer, and we got computational modeling. Why can't we alter the geometry and see, using computational modeling, see where the blood goes? And I imagine that was the genesis of surgical planning, which is the next part of his research I wanted to quickly touch on. And you have to remember, at that time, there was no guideposts. This was all done from scratch. So Ajit and his team had to make this workflow from the very, very beginning in terms of surgical planning, using the medical imaging, image processing, looking at the current flow structure, and potentially looking at all the different virtual possibilities for surgery. Then doing the virtual surgery, then doing the computational analysis for each one of those to decide what might be the best one, and then trying to implement the best one in the operating room. This was the first paper that we published on that in 2009. And here's some of the blood flow profiles that you can see right here. And they're not just pretty pictures. Ajit was able to quantify how much liver flow, for example, went to the left pulmonary artery during the cardiac cycle. And not only that, to change the geometry of that Fontan circuit, to be able to see where the blood was going to go with computational modeling, and was very successful with that. And then probably another idea that he thought of was, well, wait a minute, we don't have to do it in a patient-specific manner. Let's see if we can design all these novel, different ways in which we can connect the inferior vena cava and the superior vena cava to the pulmonary arteries. In 2007, the OptiFlow combination was proposed, and then a more realistic surgical version of that was called the Y-graft. And it turns out that when that was studied immediately after the surgery, it turns out that things weren't going exactly the way we had thought it was going to go. And so, to his credit, he said, you know what, we're going to be honest, and we're going to tell the world that this was a good idea to start, and it wasn't really working out well. And so we told the world that in 2016. However, when we got follow-up for 3-4 years, and it turns out that it was working the way we were supposed to, it just, we didn't give it enough time. Well, we told the world about that as well in 2020. So it was a great idea. And now we want to finally move on to clinical care and how Ajit's work has affected clinical care. I'm going to do 3 quick examples. One is being able to relate power loss, or in that Fontan baffle, with exercise performance, that was published in 2015. If you look at on here these graphs, the y-axis is the amount of exercise one can do in terms of oxygen consumption and work. And as you can see, there's a strong inverse relationship, right? The less the power loss, the more oxygen you can consume and the more work you can do in the exercise lab. But as the power loss increases, the less you can do and the less oxygen you can consume. Now these patients also get liver scarring for some reason. And we decided to throw our efforts, Ajit decided to throw his efforts into looking about whether or not any bioengineering parameters can predict that. So we looked at patients who had their MRIs 7 years beforehand, and they had their liver biopsies currently. And it turns out that the liver scarring on the y-axis and resistance in that baffle, in that conduit on the x-axis here, and pulmonary artery stenosis, you can see had a strong correlation, positive correlation. The more resistance there was, the more scarring there was. The more stenotic the left pulmonary artery was, the more scarring there was. So this was another way in which we can take fluid mechanics and actually apply it to clinical care. And then finally, the last thing I wanted to point out is that there are things called quality of life instruments that basically take into account your quality of life in various domains, whether that be physical or mental. And it turns out that, and this is now still in press, and yes, that's counted in the 899, we still need one more. I'm just kidding. And so we were able to correlate this hemodynamics by computational modeling with these quality of life measures. Here's the univariate analysis, but I want to point to the multivariate analysis here, where if you look at normalized power loss, high resistance in that conduit, and maximal pressure drop, you can see these coefficients are all negative. They were highly significant. They were significant with an adjusted R value, which was amazing considering everything that can go into quality of life of 0.2, meaning that the higher the power loss, the higher the resistance, and the higher the pressure drop, the worse your quality of life is. So I wanted to finish by asking the question, is Dr. Y really retired? He's still writing papers. As you can see, we have one in press. He's still submitting grants. He's still talking Fontan science with everybody, including me. So I wanted to borrow a quote from pop culture. I hope you all have seen Top Gun. This is Top Gun, Dr. Y, and I want to take a quote from the original Top Gun, where Kelly McGillis speaks to Tom Cruise and says, "You're not going to be happy unless you're going Mach 2 with your hair on fire." And that's exactly how I think of my friend and colleague who I don't think will ever slow down with that. I think he just loves what he does so much. And I want to just basically say thank you. And I've learned a lot. And most importantly, thank you for your friendship. And thank you for all the great collaborations. Thank you very much, everybody, for your attention.
We'll open it up for a few questions or comments. Did you want to rebut first?
He's going to save that for the end. Nobody Fontan engineers? Well, once you see how cool it is, you like it. And remember, you still have that, we still have that challenge of 10 people putting his name on abstract so we can make it a cool 500. Thank you.
So Mark, actually, I will have you introduce Pedro Del Nido, who couldn't be here, but let me, while I pull up this video.
So as you all may or may not know, Pedro Del Nido is one of the most superlative pediatric cardiothoracic surgeons in the United States, if not the world. And he and Ajit have been in a many-year collaboration together. Pedro is not only an incredibly gifted technical surgeon and incredibly smart, he is also just a true gentleman. It's nice to see somebody who is incredibly smart, incredibly well accomplished, to also just be just a plain old good guy, kind of like Ajit. So without further ado, I'd like to introduce Dr. Del Nido.
First of all, I'd like to thank the organizers of this special tribute to Professor Ajit Yoganathan for the invitation to participate and giving me the opportunity to spend some time reminiscing about a colleague that I've known for over a couple of decades. I'm here wearing two hats, one as a pediatric cardiac surgeon who has pursued research in the field of congenital cardiac surgery for over 25 years, and have interacted with Professor Yoganathan throughout much of this time. And my second hat is as representative of the American Association for Thoracic Surgeons. Professor Yoganathan's contributions to the worlds of biomechanics, and in particular to the world of prosthetic heart valves and understanding the function and the durability and how these valves perform in vivo has been not only seminal, but has been critical for the development of new prostheses. And I think everyone has already acknowledged the fact that virtually no valve in North America has been placed in a human without it being evaluated, at least in part, by Dr. Yoganathan's lab. And that's a tribute to the importance that his scientific contributions made to the clinical world. In addition, he has played an important role in the regulatory aspects of heart valve evaluation. And this publication is a very recent example of his continued contribution to this field, working to develop novel standards for labeling of heart valves, as this problem is widespread and has significant impact on clinical outcomes. But I'm here really to recognize his contributions to the field of pediatric heart disease and pediatric cardiac interventions in particular. I think there are two areas where we must recognize the importance of his contributions, and I'd like to focus on those. The first one, obviously, pediatric heart valves. This is an area that's been long ignored, and in particular by the manufacturing community as well as the academic community. However, Dr. Yoganathan recognized this unmet need, and in 2013 organized in conjunction with the Food and Drug Administration and representatives from industry a workshop to develop new paradigms for obtaining marketing approval of pediatric-sized prosthetic heart valves. This was a novel effort. It brought together academicians in the field of pediatric cardiac surgery, as well as engineers that have studied prosthetic valve performance and hemodynamics for many years, along with regulators from the FDA and industry partners who were interested in contributing to solutions to this problem. The results of this work was a publication, which was in the Journal of Thoracic and Cardiovascular Surgery at the time, and it came up with recommendations that were derived from the ISO standards as well as the draft guidance from the FDA that provided for hydrodynamic durability and fatigue testing for pediatric heart valves. This was a seminal paper that resulted in many follow-on publications, but more importantly, it gave the impetus for industry, in this case St. Jude, to develop and evaluate one of the smallest pediatric mechanical heart valves that's currently available. This was done through a clinical study called the HALO study, which was a single-arm prospective investigational study to evaluate this mechanical valve in the mitral position in young children, and eventually led to approval of this valve, all a direct result of Dr. Yoganathan's initial work and giving impetus to industry to pursue solutions for children. This also resulted in inspiration of some of my own work to address the problems of bioprosthetic valve performance in children. This is a well-known problem that calcification and deterioration in children, particularly in younger children, is very accelerated, resulting in durability times that would be unacceptable in the adult world. Nevertheless, this is all we have in the pediatric world. And even in very young infants, the need for reintervention is very high in these patients. Based on these observations, as well as collaborations with Dr. Yoganathan, we sought to come up with a solution to this problem and came up with the idea of a biomimetic valve mimicking a venous valve that is able to expand very rapidly without any increase in leaflet size or leaflet mass, and came up with this mechanical version of a venous valve. It can be, in this case, balloon expanded by a minimally invasive catheter intervention, bringing a valve from a diameter of about 12.5 millimeters all the way up to 23 millimeters, which is close to an adult size. This work led to a publication in Science and eventually to an effort to manufacture this valve in clinical studies, and is now implanted in an early feasibility study in young children for evaluation for pulmonary valve replacement period. The goal of this was to avoid the multi-operations that children are subjected to because of the poor durability of bioprosthetic valves. Perhaps one of the more significant areas of research and contributions from Dr. Yoganathan to pediatrics is his work evaluating the treatments for single ventricle disease in children. Single ventricle disease encompasses a broad range of congenital heart defects in children, most of which are incurable. We subject the children to multiple palliative procedures in an effort to at least establish closer to normal physiology, recognizing that it has many limitations. The ultimate solution for this, to improve at least the oxygenation of children with this, is the total cable pulmonary connection, which is a method to bypass the heart mass by simply connecting the cava and cable venous return directly to the pulmonary arteries without going through the cardiac muscle and without the benefit of the kinetic energy that's imparted by the ventricular contractions onto the pulmonary circulation. What is well recognized, however, is that the longevity of these children with this type of physiology is limited, and this is an example of a study showing that although this kind of physiology can last for a decade or two, usually by the third decade, most of these children are beginning to die of complications of this physiology. Well, Dr. Yoganathan's contributions in this area are numerous, and I would say substantive and seminal. This is an example of work that he did very, very early on, looking at the geometry of these cable pulmonary connections and applying computational methods to understand the losses in kinetic energy with abnormal connections and the impact that this may have on the overall hemodynamics of this physiology. This work, which was, you'll note, published in 2001, this is 21 years ago, he was working on this problem, and has subsequently spawned similar work in several other laboratories throughout the world to try to improve the hemodynamics of this particular surgical procedure. His contribution at the time was to demonstrate that depending on how this connection was made, power loss, in other words, the inefficiency of this circuit, could be optimized by some simple adjustments to the surgical procedure, a concept which is now widely applied throughout the world by clinicians. He also went on to actually develop novel approaches to this, and we jokingly call this the Yoganathan graft, in other words, a Y graft, which is really an effort to improve flow distribution of hepatic factor, which is critical for lung health in children. This is another example of a contribution that Dr. Yoganathan came up with and has been applied in the clinical world. I won't go into all of the contributions that he has made, as Dr. Mark Fogel will be presenting this work in more detail and will give you better examples of Dr. Yoganathan's contributions. And finally, to put on my other hat as a representative of the American Association for Thoracic Surgery, which is the oldest professional organization of academic surgeons, established in 1917, it's been around for over 100 years. The organization in 2020 recognized that there are individuals who may not be cardiothoracic surgeons, but who have made seminal and transformative contributions to cardiothoracic surgery by nature of their scientific contributions within their own field, should be recognized and established an honorary fellowship to the organization. As you might imagine, the inaugural recipient of this honorary fellowship was our own Ajit Yoganathan. This is a publication in the Journal of Thoracic and Cardiovascular Surgery, which is the official publication of the AATS, celebrating the contributions to cardiac surgery with this honorary fellowship from the AATS. And I quote from that article, Dr. Yoganathan, through his collegiality and knowledge instruction, has helped us understand disease processes and prosthetic valves in a way that goes beyond physiology and pathology, but also incorporates fundamental engineering principles. So I'll end there to recognize an individual who truly is the king of hearts for over 40 years has made contributions not only to the field of cardiovascular fluid dynamics, but also to the clinical world, and in particular in my area of pediatric cardiac surgery and cardiac diseases. Thank you very much.
So Dr. Del Nido did mention to me that he really wanted to be here to thank Ajit for all of the contributions in person. He was unfortunately conflicted because he had another talk scheduled, basically an invited lecture at another conference. So I'm going to introduce our next speaker, who is Erin Spinner. And Erin Spinner, Erin, can you hear us? If you can unmute. Can you say something again? No, I think. Hey, Erin, can you hear us? Can you say something? I know. No, I think she can hear us. We can barely hear her. Yeah, I guess we can barely hear her, but maybe.
We have a whole bunch of engineers, kids. I don't know.
Aren't you going to do that?
That's why, but.
I appreciate it.
Any luck hearing the
Yeah. Okay, we can hear you now.
Okay, you can still hear me?
Yep.
You have to mute that.
There's just a bad echo on our line. Is there an echo for you guys?
Okay, not anymore.
I can't hear you guys. I think.
Not anymore. So.
Oh, this is better, Prasad.
Okay.
Can you hear me?
So, yes.
Oh,
yes,
this is perfect. Perfect. Okay.
So, yeah, let me introduce Erin Spinner, who is, I believe, the Vice President of Clinical Affairs at Abbott. Erin, correct me if I got that wrong, but...
Well, that would be a great promotion. I'm just director for clinical science in structural heart for Abbott.
Yeah, so Erin and I, we were both in Dr. Wai's lab, and I was a postdoc while Erin started as a graduate student, and she worked in the area of tricuspid valve biomechanics, and has went on to work at the leading industry, including Edwards and now at Abbott. So, Erin, you can share your screen and go ahead with your presentation.
Okay, perfect. Thanks, Prasad. Can you guys, okay, it looks like you can see my screen. Great, and sorry I couldn't be with you guys today, but I really am honored to share a little bit about the contributions that Ajit, Dr. Wai, Dr. Yoganathan has made to industry. And I'll try and do that here, and I think I've got about 12 minutes. So you'll notice my talk will be a little bit different than the previous talks, but I think there's just a lot to share about Ajit's contributions to industry. So really, I think most of us that have had the pleasure of working with him, not only in industry, I think as clinicians as well as his own students, really see him as a partner whether it's in the clinic or in industry. So I'm going to focus my talk more on the industry side. So one of the things I want to share today, I was kind of looking through some of the articles on Ajit and different things, but one of the quotes that stuck out is that, you know, there aren't many people in any industry with such universal name recognition and integrity. And that was said by Phil Igling, who was our CTO at Abbott, but who has since retired. And I know Ajit and Phil had a long-standing relationship. But I really think this is true, whether it's, you know, you come to work with Ajit in the lab or you've worked with him in the clinic with Dr. Del Nito and Dr. Fogel talking about their experiences, or whether it's in industry. So you'll find that there are many people, no matter where you are, who have not only heard of him, but his work. So I think that goes a long way. So one of the things I think Ajit has been so successful in really building his reputation and partnerships in industry is his ability to really inform the field. I think so often we look for information, we try to find answers to problems, and I think Ajit's been really successful in that. You know, you can see that Dr. Fogel kind of showcased this in his opening talk, but you know, looking back, Ajit's had more than 450 peer-reviewed journal articles and leading biomedical journals with high impact factors that reach a broad community. And in that, summarizing this data in 40-plus book chapters. So this is something that not everyone can say in their achievements in their lifetime. But I think it's kind of important to look back, and as I talk about the partnership specifically with industry, it's not just putting data out, it's putting relevant data out. And I think one of the things Ajit did so successfully was partner with industry in different ways, doing experiments in the lab. So here's just a few that I pulled out. One is working with the Edwards Intuity device. So that's really testing these devices on the bench, providing solutions, answering questions, working with industry to really better understand the devices that are being put out there. Here's another one with VentureFlow and looking at a pulse pump for failing Fontan support. So really testing this system out on the bench, understanding how it works, how it doesn't work, and taking a closer, more controlled look. And here's just another one, a more recent one with the Lampoon device that assists in transcatheter mitral valve replacement. So really partnering with these physicians, with clinicians, with industry partners to better test and understand the devices. And I think he's done that throughout the years. So that really brings me up. I did some Google searching to how I heard about Ajit. And I think one of the things that he's done also so successfully is reaching out to the field. You can't help but be a part of the field when you have so much information and data that you're putting out there. And so this was an article I read back in 2005 when I was looking. I don't know if Ajit knows this story, but when I was looking to apply for graduate school, knowing I wanted to go to graduate school, but not exactly sure what I wanted to do. And I was actually in industry at the time. And I came across this article about Ajit and his work in a trade magazine. And really, this article was focusing on a view from the top, so looking at the educational sector and how they discover more about its contribution to industry. And one of the things Ajit talks about here, and I'm going to talk a little bit about more, is training the future. You know, whether it's undergraduates or graduate students, and really putting them out in the workforce. And that really got me interested, and they had asked the question, how much interaction do you maintain with companies manufacturing finished medical devices? And when I saw this, you know, Ajit talking about his work with Medtronic, St. Jude, Edwards, Sorin, J&J, Box and Guidon, etc., these are all the top companies. So if you're looking to be translational and work with these devices and these companies, his really was the perfect lab to go to, and that's what I did. And while I was there, I had many opportunities to work with some of these companies. So I think that was one of the things Ajit has done so successfully. And how did he do that? How did he reach out to the field? I think it's really has to do with, you know, his 40 plus years of collaboration with over 40 companies in industry. That says a lot. And I, you know, really looking back and reflecting, I think this was really pioneering of you, Ajit. You know, I think there was always this division between academia and industry, but you really brought those together, made it welcome for students to work with these companies. You know, maybe not always in internships, but partnering them with things they did in the lab. And so if you were a student that wanted to someday go to industry, you had that opportunity. And we see the trends, I think, in graduate school and what students do with their PhDs changing. Originally in biomedical, it was training a lot of professors for the initiation of these different programs. But I think we've seen it change a lot. I sit on different advisory boards for different BME programs, and there is a lot more emphasis on the job training, working with industry. And so I think, Ajit, you really successfully did that early on in your career and consistently throughout. So I know that's something not only myself, but many other students were really grateful for. So here's a few more quotes. These are from some of Ajit's, I think, you know, closest, you know, what originally started as partners in industry, but I think you guys quickly became friends. I've seen you guys work in a professional environment and work quite well. So Tim Kelly, who's a senior distinguished engineer from Medtronic, sent me this to say about Ajit. His leadership in the development of international heart valve standards, combined with his patient-centric focus and unwavering demand for scientific rigor, have set the standard for the heart valve industry. So I think that is really true and resonates. Sal Marquez, who is a senior director at Edwards, also said that he's led the industry in developing standards that improve the way devices are developed and tested. And I know Dr. Del Nido touched upon this in his talk, but this really is true and really is the case. And I think that's one of the ways that Ajit really bridged the gap between industry and academia. So I just want to talk about his contributions to really standardizing the field. For a long time, there's been new devices, originally started out more surgical, but we've really moved more having a lot of innovation in the transcatheter space. And Ajit, for some time, sat on the International Standards Committee, the ISO committee, for developing these standards for various devices, and he was the chair for quite some time. And I really had the pleasure of sitting on this committee really once I first got into industry, and I'm still on the committee today. But it's really a collaboration between clinicians, industry, technical experts, and notified bodies. And that all sounds great, and I put this little diagram here of, you know, us kind of working together and as, you know, the hands together, but Ajit knows firsthand it's not that easy. And I think one thing Ajit really does so successfully is bring the right people together and get us to work together. And that's hard, and I think that is a unique skill that Ajit has had, and have met a lot of people along the way, and people with very strong opinions that don't always see eye to eye. And so from that work that he's done, the first edition cardiovascular implants, so this is for cardiac valve prosthesis, came out in 1978 and was most recently revised in 2021. And then there was a new standard put out for cardiac valve repair devices. You know, Ajit saw a gap in standards for these type of devices, and once again got the group together to really write these standards, and they continue to be revised, and he plays a really important role. So I think that contribution itself, these are the standards by which companies just as Abbott, Edwards, Medtronic strive to test their devices. and really work with the notified bodies to meet the requirements and get the devices approved. So it's quite the feat to play such an integral role in this important standardization. So I talked a little bit about this previously, but I think, here's another person that Ajit has worked with for quite some time, and Anne Graves, I've worked with her as well. She, Prasad tried to give me the distinguished title of VP. I don't have that, but Anne does. She's the VP of Clinical and Regulatory Affairs for our Heart Valve Division, and has nothing but great things to say about Ajit. And really the thing when we were talking about Ajit that really came out was that, he excels at bringing people together and inspiring collaboration. Like I said, that is not a skill that everyone has, and not all people. And I think, Ajit, you've successfully done that in many ways. So thank you for that. And that really leads me into his ability to connect the field. I just pulled out a few publications here that I worked at while in Ajit's lab, but when I went back and reflected, there's so many people that I continue to work with today. So Karthik here, this was on my first paper in Ajit's lab. He was until recently my boss, but it is in a different division in Abbott. We've continued to have a friendship and relationship. Dr. Tarani, who is now at Piedmont, he was previously at Emory. I worked with him, but I still see him on a regular basis in different steering committees and clinical meetings that I attend. Another paper, and Dr. Del Nido talked about this, and the honor that both David Adams and Dr. Del Nido gave to Ajit. But I work with Dr. Adams. He is a co-PI of a large pivotal trial that I am currently running. And I think it's that relationship and foundation that we built in Ajit's lab, going back to his integrity for data, that really, has made it the ability of Dr. Adams and I working so successfully together. It really built that foundation. So other physicians that I work with today, and their staff that we work with in different ways, and it's just nice to maintain that connection. Undergraduates that Ajit brought into the lab. I think that was another thing you did so well, Ajit, is not only the graduate students, the postdocs, but the undergraduates as well. And they have since come to industry and played a vital role as well. So that being said, I think what was once first talked about in the article that I originally read about Ajit, it rings so true today. He really has been so successful at training the field. This is just a snapshot of the people I know at Abbott, but we are a broad, big company. And just looking at some of our divisions, that are most relevant to valves, there are many of us that serve different purposes within the Abbott community, but these are just people that directly came from Ajit's lab. If you were to look at those that were trained by the students or postdoc that came out of Ajit's lab, the span is even broader. So I think, your ability to train the field and make connections, really, anyone that was in the lab knew it wasn't easy. So I think that also helps bond us students in the lab. And so whenever we get a chance to get together, we kind of reminisce about those times. So like I said, this is just us here at Abbott. But I looked at, a recent article that was published about Ajit, and, just looking at the pictures themselves, these are some of the students that were in the lab when I was there. And you can just see where we are across the space, really working in the top companies. So Medtronic, Abbott, Edwards. So it doesn't really stop, with his ability to train students in the lab and work with industry in the lab. But it's really the students that go on to then play an important role in industry, which we are so grateful for. And these are some of the best employees that we have. So I'll just end this with saying that Ajit's not only a partner, but a driver influencing the aspects of medical device industry. And really, I'll just take something from, what you always like to say, Ajit, from bench to bedside, but really from bench, whether that's research in the lab with industry or working with companies in their own R&D space, to bedside, and that's really the regulations and the standardization of the way that we do things. So with that being said, I'd like to thank you for myself and many others for your many contributions to industry. So thank you, Ajit. Hopefully you guys heard all that, Prasad.
Thank you, Erin.
Yes, thank you. Any questions or comments for Erin? All right, if that's the case, then our next speaker is Professor Sachs, who will share some thoughts of his long-time collaboration with Ajit Yoganathan.
So I've been invited as the token Biomechanics person for a meeting surrounded by a bunch of very fluid types. When you find out that your colleagues hit their 70th birthday, the first thing you think about is how much longer will you have before you hit the same milestone. You first think you're much younger than they are. But all joking aside, it's been a this is probably a little summary of the little article I wrote for Ajit and see that came out last year, and I was really struck on what to write because I've been working with Ajit since about 2000, early 2000s. It's been a good 20 years, and it's been a very dynamic and very, very fruitful collaboration because we're very complementary skills, and yet we have a very common interest. This is just the summary at the end. If you want to read it, you can download it. The main thing I found is a lot of pressing questions. Ajit, I work primarily on the microvalve, and we provide not only the technical side, but very high-level perspective, insights, understood what was important, working with state-of-the-art facilities, worked with a number of his people. It was very much a pleasure to work with, very professional. And for those of you in academia, anytime we had a subcontract, it was always done on time, unlike everybody else I work with. So, but these are, and it's really amazing to me that we hit this milestone because, like most of us, I feel there are quite a bit more to do. This was a review I wrote a couple years ago to kind of summarize our work to date. And we had several large NIH grants. And really on ischemic mitral regurgitation, and it's a very, very complex disease. Been at it for a very long time in terms of things like annuloplasty ring and all kinds of treatment. And what you don't realize is how complicated the disease is. It sounds like if you look at online videos on YouTube, these appear to be very straightforward. In fact, the videos make the surgery look like you yourself can do it. Once you understand what really goes on, it's extremely complex. And so one of the things that Ajit and I worked on is this whole interplay between the left ventricle and the microvalve, and particularly using his facilities for reconstructing the valve, really understanding it. He had very unique experimental capabilities to set that problem. This includes this micro-CT technique with this sort of fluid dynamics chamber, and looking at really some very, very basic questions. How much the leaflet deforms, how fast does it deform, what happens when the cords are displaced in different ways. Very basic information, surprisingly missing in the literature. And we were able to really try to reconstruct it and develop a much better understanding of what's the basic dynamics, even the healthy valve, let alone the ischemic valve. This allowed us to build a number of models. And at this time, we were first working together, doing what I was called archival model. It is models based on animal tissue, ovine model in particular, and just understanding the closing dynamics and how what happens just in the sequence of closing. This is all models we built from our collaboration. And then learning to develop things like what are the strains of the cords, what goes on inside the leaflets themselves, why the cords the way they are, what happens, how the cords insert into the main body of the leaflet. Very complicated, something we worked on for several years together, really fascinating area, and really get you understand how tough this is. Remember, these, even though there's a lot of surgical repair of these valves, they weren't, from evolutionary pressures, not designed to be sutured, ringed, stapled, what have you. There's a lot that goes on. It's really fun to understand the dynamics, how the underlying connective tissue structures adapt to the loading and different loading. Now, what these earlier models allowed us to do is begin to develop, and as I've talked with many people here at this meeting, is that so much of the field is moving more toward imaging-based techniques because the imaging technology is really caught up. Just using 3D ultrasound, most of us remember the bad old days of ultrasound where, you know, you would question what you were actually looking at. And then the technology is evolved to the point that we can actually reconstruct very high fidelity shapes of the aortic valve, of the mitral valve, quite well from human data. In fact, we do this now quite routinely. But our understanding of how the valve works came from our long studies of in vitro studies with Ajit on getting that effect. Everything we built on was built on that work. And I don't know if Chuck Howe is here with me, but Chuck Howe he's an associate professor now at the University of Oklahoma, and he helped develop our first models. And a lot of this, to give you an idea, it's like when you develop models of the mitral valve, it's like really basic things like where do you put the cords, how many, how they're placed, does it matter? And it turns out it makes a big difference, and we developed a number of systems on the left using data from Ajit's system to develop understanding, because we knew what the root deformation was. We knew we had very high precision information, not possible even by today's standards, in vivo work, and very difficult doing even in animal work. But allowed to do this. So what you see on the right are now what we create these synthetic chordal systems that we use to create, that you can get the shape from ultrasound, but you can't get the cords, although there are some reports of getting cords from CT. Ultrasound is really the clinical imaging modality. And then now where we've gone now is move this to the next level up, where we're looking at how the ventricle interacts with the valve. We've done a number of simulations of this and built these very high fidelity models of the mitral valve incorporated into the left ventricle. And we've looked at parametric studies of how different portions of the heart and the different simulated infarcts actually affect how the valves are tethered, how it affects this. And now we've moved toward studying this all in vivo simulation. All in silico simulations, excuse me, showing about how the different infarcts affect the valve, how it performs under the different major classes of infarcts, and they're all very, very, very different. And it's not a single homogeneous disease, it's very, very, very patient specific. A lot of this coming out. And then since then, we've moved to looking at other computational techniques, again, for imaging-based information, built all upon our collaborations with Ajit, looking at how the leaflet itself deforms. Again, very basic information, how much the leaflets deform when they close. And does this change with disease? And the answer is yes and yes. And in fact, we're able to now develop sort of biomarkers where we can detect certain characteristics of valves that occur when they will likely be regurgitant, up to about an 83% success rate. And then we're moving still into the mechanobiology part, so we've been working on this. This is another area that Ajit and I have worked together on, where we look at just what happens if you put a ring on a normal valve or even on a pathological valve, and integrating this down to the cellular effects and looking at how the cells respond dynamically. And then remember, these are living systems, and part of the problem with long-term prognostics is that you can get a repair to work within a relatively short period of time, but long-term successes are very problematic still, and part of this is what's going on in the leaflets themselves. Ultimately, one of the things that Ajit and I share is this engineering approach, and I actually got into this field, in engineering approach, from something he said, and I can't remember, I was trying to find the citation for this, but I couldn't, but he said something along the lines of, we can design 777s, I think it was one of the first aircraft by Boeing, to be completely designed on a computer. Why can't we do the same thing for medical devices? And if you've seen what goes on, and how what goes on in how they complete Boeing, it seems so much more complicated, but there's so much more that we know about those systems. And this whole multi-scale idea is something that we've shared a great interest in together. And it's still a big adventure, still a lot that we don't understand, even at a very fundamental level, let alone applied level. So I just want to thank you for all the years of collaboration. It's been fun. I'm still trying to get him the right grants. I think that's failing right now, but that's okay. And I just want to thank him for a wonderful last 20 years of collaborations, and hopefully we'll write a few more abstracts with his name on to get citations up to a reasonable number. Thank you very much.
Thanks, Michael. Then I think we'll just move on to our last speaker, Prasad. So again, thanks everybody for coming again for this honorary symposium. I'm going to be presenting. I won't go through all of the literature. Obviously, all the speakers have gone, before. Mark and Pedro and Michael and Erin have done such a great job with just outlining the intellectual contributions. I'm going to try to take a different angle to this talk. So, Professor Ajit Yoganathan, King of Heart. So, I'm going to be thinking about what does it take for a person to become a king of the heart. And I guess Mark mentioned Top Gun, so I actually remember watching the new one with my kids, and in that there's a scene in which Tom Cruise says, it's not the airplane, it's the pilot. So remember that Ajit started at Georgia Tech in 1979, and Georgia Tech was, I would say, an underdog in terms of its prominence in the field of engineering, but that's where the story began. And I made the slide this morning. I put in Ajit's parts. I feel like Ajit's story is unique in the sense that his story mirrors his own philosophy, and I feel like that could give a little insight into what kind of a person can become a king of heart. And I'll touch on some of the things that I feel is part of his philosophy, which is ingrained in translation. I put Winnie the Pooh because I think as a member of the CFM lab, everybody gets to learn about the philosophy through one slide, which is titled Winnie the Pooh, and then I think that has fueled a lot of service and love for the field and the patients and the mentorship and so on. So here's basically the slide that I put here that I found from some of the slides I got. So the philosophy is explained here pretty well, and I'll just read it. So in this passage, how would it be, said Pooh slowly, if as soon as we are out of sight of this pit, we try and find it again? What's the good of that? Said Rabbit. Well, said Pooh, we keep looking for home and not finding it. So I thought if we looked for this pit, we'd be sure not to find it, which would be a good thing, because then we might find something we weren't looking for, which might just be what we are looking for really. So this kind of captures, I believe, Ajit's humble beginnings, going back to when he started at Georgia Tech after finishing his PhD at Caltech in 1979. Perhaps Georgia Tech was the pit that he went off, because I was looking through his CV, and it said that his research interest was polymer rheology, and that was kind of, I guess, what he was hired for. But clearly that pit led to something else what he was looking for, and he wasn't looking for polymer rheology. It was really, he found what he was really looking for, which was the world of structural heart and heart valves. I found this picture. I don't know who drew it, but it really is a nice drawing with the heart and all of the valves, like kitchen faucets. But I believe Ajit found and created the whole field of heart valve engineering. So this is where you have to question what kind of mind goes in and just creates a whole new field. It's not just publishing in a field that already exists, but you actually are creating a whole new field. So some of the things to note was that there was also a Medical Device Amendment Act that went into place in 1976, and Ajit was instrumental in setting the initial standards, and I think Erin really described this in greater detail. But that set the stage for the birth of a new field, and the leadership that Ajit showed with what Erin was talking about is bringing people together with clinicians and industry and academia. That's kind of how the whole field started, with him at the center of it. So here are some of the early letters that Ajit received. I know you can't read some of these. One was from St. Jude Medical, early 90s, and then another one from Medtronic. Both are from the CEOs of these companies, basically gifting with a book and essentially saying thank you for all your service to the industry, for they have really learned a lot from those little projects or consulting and working with the ISO and the FDA to really set the path for industry to make the impact which they make, right? I have this video from Mike Masalam that I'll
I'm
play
sorry
here.
I can't be there in person, but on behalf of all of the employees at Edwards Life Sciences and patients around the world, I want to congratulate you on your well-deserved retirement. You should be very proud of all that you've accomplished in biomedical engineering and research. Both the advancements in science and the development of future leaders is distinguished. And during your impressive career, you became the most influential independent consultant to the FDA with respect to heart valves. We sincerely appreciate all of your efforts as they've led to more patients receiving the care they deserve. I want to thank you for all the talent that you've developed now working in the medical technology industry. We have several at Edwards who've studied under you, and no surprise, they are making valuable contributions as we continue to innovate to transform patient care. Thank you for your friendship and partnership. Congratulations again, and please continue to take great care of yourself and your loved ones.
So that was Mike Masalam from Edwards Life Sciences thanking Ajit, and I wanted to note that every heart valve that has been cleared at some point in time has gone through Ajit's hands in the lab, and that is something to say, right? It really is a testament to the amount of impact. Ajit made impact not only to the industry, but also to academia. So Ajit, again, thinking about what kind of a mind would go into all of these areas, right? So impacting Georgia Tech and Emory, Ajit worked alongside, he's one of the founding fathers of biomedical engineering at Georgia Tech and Emory, and here pictures, you can see, I believe he had great friendship with Don Giddens as well as Bob Needham, and together they really, I would say that was the beginning of the whole field of biomedical engineering, because Georgia Tech was one of the first biomedical engineering departments, and this was kind of the blueprints of how a biomedical engineering department has to be set and what kind of a model really makes it work. And Ajit was at the epicenter of some of those. Impact to clinical care on a daily basis. So this is a slide. This is a circulation, article from Ajit early on that just simply demonstrates that you can apply the Bernoulli equation using Doppler velocimetry, or using Doppler. And I think Mark did touch upon this. Some of this data probably made its way into that book that Mark read earlier. But this is where you basically have an optical technique called laser Doppler velocimetry and ultrasound Doppler. And essentially this paper shows that what you're measuring from ultrasound Doppler and using the simple formula called the simplified Bernoulli's actually works. And the data at the bottom shows that those velocities can actually relate to the catheter-based measurements of pressure. And this, you can think about every time a patient walks into a cardiologist's office and gets an echo, this is the paper that really started and made an impact. So now you can say that every patient where pressure gradient is measured using Doppler, that was basically because of Ajit's early work. And again, think about what kind of a mind would really start thinking about that level of impact and being at Georgia Tech at that time. And again, going back and thinking about it, it's really the pilot, it's not the airplane that you're flying. Impacting real lives. And how many of us can really say that you have not only published so many hundreds of papers, but actually saved lives? And here's a letter that Alan shared with me, and this is a letter. Basically, I'll read it quickly. I blanked off the name. My name is blank, a cardiac patient of Dr. Ann Kavanaugh from Mount Carmel Hospital in Vanderbilt. Over a year, I called her to discuss my unique and complex cardiac condition. As a result of that conversation, you came up with a solution to help me. And when Dr. K explained to me that I need another operation, which turned out to be my 5th, I was scared, sad, and completely overwhelmed, especially when she told me what had to be done. And the fact that she was not sure how it can be done. At the time, my oxygen saturation levels were low 80s at the best and were likely to worsen in time, but her reassuring words and care for me over the following visits helped me understand how serious my condition was. And then it goes on saying, I remember particularly a visit where my entire family went with her, and it was then that Dr. K explained that the team of engineers from Georgia Tech were going to help by creating models of my heart in order to create the best route for blood to travel to my right lung from my liver. So here's a patient whose literally life got saved, and this is how many of us can really say what actually happens in your lab directly touches a patient and their loved ones. And again, going back and thinking about the philosophy, of what kind of a person really gets to be the king of hearts, and that's what I think about that. And Ajit is an extremely passionate person. Like, I know him from my time at Georgia Tech as a postdoc, and later on, even after I've gone, he has been, in my mind, what drives everything is the love and passion. And I'm showing here pictures of family. Anant is sitting right here, was looking at a heart valve simulator just a few years ago. And the picture of the family dog, Dr. Boz, is shown here. All of us in the lab really know the significance. And in my mind, it's really about truly loving and passionate about patients, about doing good for the community, the academia, the department, and knowledge, right? And that's where I feel like Ajit's true, the reason why somebody becomes a king of heart really emerges. So thank you for impacting us, impacting industry, academia, but finally you have impacted us as the future generations by teaching us key lessons. And I personally transformed over the years. I finished my graduate school with a degree in civil and environmental engineering. I was so passionate about fluid mechanics, but Ajit transformed me from a person who was passionate about fluid mechanics to a person who was simply passionate about making an impact and bringing translation and bench to bedside. And I believe that's what has happened to all of us. Erin and Karthik and all of those names that Erin was showing was really how Ajit touched so many lives through his mentorship, which I believe at the core was driven by true passion and love. So here's a image from my time during the lab. This was, I believe, 2007 or 8. Erin hasn't changed at all. I have grown a lot of gray hair since then. So I'll end this here. Thank you, Dr. Y. We really love you, and congratulations on such a great 40 plus years of impact and service. Thank you.
I think now it's the rebuttal. Floor is yours.
Yes, it's good to see people. Well, I don't know where to start, but first and foremost, I want to thank Prasad and Keith for organizing this session this morning, as well as this symposium. Obviously, thanks to the SME Bioengineering Division, for which I've been involved with for 35 years. And I know we didn't ask Keith to say a few things, but I'm sure he will have him make a rebuttal. So, yes, I have retired, and now, but at one point, Keith, I told you something.
He told me many things.
Keith and I go back a long time, mainly through a person who I wish was here, a good friend and colleague whose careers parallel each other, both from our graduate days as PhDs in chemical engineering and then getting into bioengineering, biofluids. That's John Cabell. John was supposed to be here. Unfortunately, he has had a few health issues and couldn't be, but he's on the mend. And I met Keith through the postdoc. But just to cut a short story short, I had once told Keith that I wasn't going to retire until he got married. I couldn't wait, and I still. So maybe I'll come out of retirement when he gets married. So, anyhow. I also want to thank Mark Fogel here. He drove down 2.5 miles this morning from Philadelphia. Our collaboration goes back 20 plus years. I didn't realize Mark had read that chapter or book, now in Nana's book. Some of the work that Prasad showed on the Doppler echocardiography was work that we did with David Sard, and at that time we had no idea what kind of impact it would have on the field. But it is one of the well-read articles by every echocardiographer today, as we have written also a series of Symposium articles on teaching cardiologists basic fluid mechanics. They do use it today. And I would like for the young people in the audience to realize that we have cardiovascular fluid mechanics or biofluid mechanics today versus when I started. At the first meeting I got up and I presented some 1D LDP work at chemical engineering. Someone got up there and said, how the hell do you know that happens in the real body? I said, yeah. About 10 years later, when our cardiac ultrasound came out, it turned out what we were doing on the bench had relevance and was not that far off. But today, with ultrasound, MRI, 4D MRI, the world is now so much that we as engineers, biofluid mechanicians, biomechanics people can contribute. And I would also like to emphasize one of the things that my career was fulfilled from day one in working with clinicians. The first person that I worked with as a clinician was a cardiologist by the name of Earl Harrison. He ran one of the biggest valve clinics at that time. This was in 1975 at LA County Hospital. He was what we would today call imaging cardiologist like Mark. He didn't do cath or anything. But he also was a deputy county coroner, and he had this collection of all these failed heart valves. And I got to see firsthand the problems that we faced with these mechanical devices, and how, as an engineer, we could contribute. And that's why he approached us. He had been working with some engineers at JPL. So the collaboration, I think, is extremely important, that you do build up relationships with clinicians, so as engineers, that you can make sure what you're doing has some value. Many of us as biomedical engineers do get into esoteric problem solving, and that's important, but I think at the end of the day, it is the translation of the impact to the clinician, and then eventually to the patient. The bottom line is your end goal should be to impact human life, whether it be through the clinician or through industry. And over the years, I've had extremely good relationships with industry, but sometimes it's up and down, because sometimes the industry wants to get their products to market quicker than one would like it to. But if you do remind them that it's patient care, then it's important that you get that information across. And there are opportunities for all of you here to be able to contribute, and I hope to see that familiar faces that I used to see coming to what it used to be the Summer Bioengineering meeting, which is now SB3C. Actually, the first one I went to was in the early 90s, and actually it was at Ohio State. It was organized by Mark Friedman. Yeah, initial meetings used to be on campus, and now that we moved to the mountains and the sea, and now here, these kinds of locations. But I think it's important for the younger generation, the next generation, to take away things that will impact the field. I've also been privileged to work with a lot of cardiac surgeons, Pedro Del Nido, who I consider, as Mark Fogel mentioned, is a premier world-class pediatric cardiothoracic surgeon, but he's also a basic scientist. He does a lot of basic science. Sir Magdi Yaqub, who's similar, who is one of the pioneers in heart surgery in London, but has done this basic biology, valve biology. So it is, to me, working with those. I've been fortunate in my career to have great mentors. And without mentors, it's tough. I heard my students say that I've tried to instill certain things in them. Things that I learned from my first mentor in graduate school, Bill Cochran. He was someone, the first day I met him, he said, don't be afraid to try and fail. Because if you try to do the perfect experiment, you will never finish your PhD. But he said the main lesson is learn from your failures. Make sure, use that and achieve what you want to do. And the other thing, he always was very, did have a very collaborative lab and also the philosophy of collaborating. Because he, not only with the clinicians, but also with industry, because he came from an industry background in traditional chemical engineering. Earl Harrison, the cardiologist that I worked with. And that's why I learned that working with clinicians, you're not going to get any work done between 9 and 5 with them. I would sit down, I would go to his house on a weekend to write papers, or in the evening, because that was the time they had. Many times with Mark, we talk in the evenings or on a weekend, because that's the... And then when I came to Georgia Tech, I probably would have seen, as I think you said something about polymers. I had to put something there other than say that I wanted to do biomedical engineering. The guy before me in chemical engineering didn't get tenure, was working in the biospace. And at that time, the only other person doing bio research was Don Giddens. I had met Don at a meeting, and we had posters side by side for 2 years before. And he was one of the first people that I got an opportunity to interview at Georgia Tech, asked to see. And at that time, you hardly got money to set up a lab. He had just gotten a big grant to set up a three-dimensional LDV system. At that time, in late 70s, was state of the art. And I spent the first 2 years in his lab, working in his lab, or at least in his lab physics. And Don has been a great mentor and now a friend over the years. We still think, and similar to John Tabell, being fortunate to have a lot of people around me that have helped. So I would like to again thank all of you for coming. I like thank Michael Saxion. Michael and I go back. Actually, we started collaborating even before the early 2000s. And in the late 90s when you were...
I don't like to think about it.
I think you were just moving to Pittsburgh at that time.
Yeah.
Yeah, so go back, and actually we've been working with microbial brands since then. But we've, as he said, we've had the opportunity to look at some basic science, but also make a big impact. He introduced me to the Bowman brothers, the twin surgeons, cardiac surgeons at UPenn, who we still work with. They've done some great animal work and stuff like that. I want to finally want to say something about the students I've had. I've been fortunate to have had great students and postdocs and research engineers who have come to train with me, rather than I say under me, because if you heard Laurie Sutton's talk this morning, it's the students that drive the lab, the research people that drive the lab, and listening to them and working with them has been fun, and it's they're the ones who will continue the work, and they are both in academia and industry, and I've been fortunate to have a great group of that. One of the things that, when I look back on, I had all the postdocs who have joined my lab over the years, starting with the first one around 1985, were people who came from traditional engineering backgrounds. I never hired someone with a biomedical engineering degree as a postdoc. And the reason was, wanted to keep the engineering aspect strong. They could learn the physiology, the biomechanics thing in their first couple of years. They make that. But the other, and Prasad, Karam here, who was doing combustion research in Indiana, when he came and joined to work on front-end work, that I look back on, is none of them went back to their traditional engineering. They all stayed in this field. So that's had some impact. They all decided that there was plenty for them to offer in the biospace. And finally, I want to thank my wife, son, and daughter, who I think is online. Prasad showed a picture of her, Tripti holding her. Actually, you didn't show the poster. That was from 25 years ago, roughly, in 1997, when I got the Wilson Award. So, take me to that. Yeah. Anila was 6 weeks old at that time, so there's go. And one of the first people I met, actually, which is, I am told, I don't know if Laurie Sutton remembers that, we were checking in the hotel, it was, the meeting was in Dallas, and Laurie was there with the kids also at that time. So it is a family of friends that we have here. And finally, I want to thank one person that I need to acknowledge who probably had the biggest impact on my life, my mother. She passed away 2 months ago at the ripe old age of 98. But the reason I say she had an impact, but not directly, immediately, that I felt she was one of the first MD PhDs in Asia, and probably one of the first MD PhDs around the world. And on top of that, she was a woman. Don't find too many of those. More recently, we talk about equity and bringing on that. And that was one of the things that I always learned was, don't look at someone's background, give them the opportunity to be successful. She had an MD degree and she had a PhD in clinical pathology. And I also appreciated her ability to balance professional life with her family life. She did do that. My father was a doctor, but he was always with his private practice. And he was taking care of his patients, she was the one. And I can tell you that in the lab over the years, we've had my first PhDs. Well, I had 2 first PhD students, Dana and Iran. And Dana, in the 4th year before she graduated, had a baby. The baby used to be kept in a little bassinet, actually a cabinet. And all the years we've had female graduate students who've had children, and I've always been supportive of that. That family life is important, and it is for us sometimes challenging, but I think that's something I did learn from my mother, seeing how she balanced, so I want to give her thanks for that. And she did, I mean, I was never thinking of going into biomedical engineering, so I will just leave you with this one thing, why Prasad showed you that. We need a Pooh slide. When I went to Caltech in 1973, from London, I went to Caltech to do air pollution research. I was great getting PhD in chemical engineering. They had a very strong system. And Bill Corcoran got up and he started talking about Krotkoff sound, that is the sound that the doctor hears when he puts his stethoscope with your blood pressure cuff. And he said, that's a fluid mechanics problem. And he said, I'm looking at something, I want to look at heart sounds to be able to. At that time he said, aortic stenosis. We are still talking about aortic. And what is the surgeon list? I was a cardiologist. Look, here's a jet. And he was trying. And my first 2 papers were looking at heart sounds and doing Fourier analysis. And trying to see whether that could be used diagnostically to predict severity of aortic stenosis. There was no Doppler ultrasound at that time. So this was 1974. And that's how we ran into Earl Harrison. He saw one of our papers and he said, I have these mechanical heart valves. Can you listen to their sound and tell me when they're getting flat loss? The problem is still trying to understand and resolve because we have thrombosis with valves can be used not invasive. But it's a full circle. All I can say is I've had a great 40 plus years. And I will continue to still do things in the background. But I don't want to write grants. That's but again, Yeah, I put my name on some of them. I think Milad owes me a couple somewhere. And so does Juan and Alan. Anyhow, thank you very much for all, everything, Prasad, Keith. I know Keith, I don't know if you want to say a few words. I've enjoyed many evenings and meetings. I mean, you're the postdoc that never came to my lab.
Yeah. Some would say the one that got away.
Anyhow, thank you much, everyone.
Thank you, Ajit. Obviously, we actually met when I was a graduate student in 1996 at a IMechE meeting. But yeah, we didn't really start getting to know each other until about 2001 when I was starting my postdoc with John. But it is, Ajit's a mentor. He's a mentor for his students, but he's also a mentor for others. And I can certainly say he's been a mentor to me over the years. And I expect him to continue to be a mentor. So it's been a real pleasure interacting with you over the years and the family and hanging out. So I would just say thank you everyone for coming out. This is really a special moment. We have these pillars of our society. They will continue to be a part of our society, but to have them sort of think about and share their experiences, their career, and their interactions with students, with faculty, with mission, is really important for us to sort of think about the future. So, thank you, Ajit.
One more comment to make. Something. Aaron, are you still there? You there?
I'm here. Yeah, I'm here.
Yeah, so you did mention, I remember you telling me about that, and actually you emailed me about that article.
Oh, okay.
Yeah, but you remember the first time you came to see me then, when you came to Tech, what did I say?
Yeah.
I'm
You
not
said you
taking
weren't
any more
taking
students. Right.
And I was like, oh dear.
Right.
Oh, okay.
No, actually, in the, round about this time, not June of 2006, I was diagnosed with severe mitral regurgitation due to a congenital abnormality. And had to undergo open heart surgery. At the time when Aaron showed up, I had just come out of, I was recovering and I wasn't sure how much longer I was going to last. I said, I'm not taking. She wouldn't take, I know, she would come by every few weeks and ask, and she did join the lab and make a hell of a contribution. Aaron, thank you for your talk. And I like that tree picture that you had, putting the family tree together there. So anyhow, so if you're persistent, you can get things done. And I've been lucky to have had grad students who would not take no for an answer.
Thank you all very much.